Hello everyone, my name is Elizabeth and today I'm presenting a quality improvement project aimed at reducing ventilator-associated pneumonia or VAP through a structured education program at a pediatric subacute facility. Today we'll cover why VAP is a critical issue, what challenges exist in preventing it, the solution that was designed for this project, and how it was implemented, what the results were, and key takeaways and recommendations. The presentation will highlight how education can improve safety and outcomes. VAP remains a leading cause of preventable harm in patients on mechanical ventilation. Despite known prevention strategies, inconsistent staff training, and limited awareness of current guidelines leave patients vulnerable. The goal was to implement a practical evidence-based educational intervention that empowers staff, improves adherence to VAP protocols, and ultimately enhances patient safety. VAP significantly increases ICU stays, costs, and mortality with rates between 20 to 50%. So, despite having proven prevention strategies like oral care, suctioning, and elevating the head of the bed, staff often apply them inconsistently. This is a largely due to mistraining, a lack of protocol standardization, and insufficient follow up on competencies. In the current subacute setting I work at, there were four main contributors identified to VAP risk. The first one was poor adherence to protocols, especially when no formal policy is in place. Second one is inconsistent education and training among interdisciplinary staff. Third was limited awareness of evidence-based strategies despite their availability. And lastly, high acuity in a subacute care where staff are often stretched thin. These factors created an environment where VAP prevention was informal and dependent on individual initiative rather than standardized, reliable processes. This project aimed to close those knowledge gaps and designed an educational program focused on oral care, keeping the head of the bed elevated, proper suctioning techniques, reducing time on ventilators when possible. And these strategies are supported by guidelines from the CDC, ATS, and SHEA. A pre-survey was established to gain baseline knowledge, and a post-survey tracked any change. Competency checklists were used during simulations to assess performance, and the objective was to implement a structured multidisciplinary program that's aimed at improving staff knowledge and confidence and creating a safer environment for patients on ventilators. While we didn't roll out a full protocol, this project served as a stepping stone toward more standardized system-wide practices. And the program was kept low cost by using existing CDC and SHEA guidelines, printed handouts and visual posters, a brief PowerPoint presentation, and simulation tools we already had on site. We also created checklists for daily use and laminated job aids for workstations. There was also administrative support that helped schedule training during regular shifts. However, we did face barriers, such as staff resistance to change was significant, and some felt it was too time consuming or unnecessary. Our resources were also limited, so it required us to be efficient and creative, leveraging existing tools. And the long term consistency remains a challenge, so we incorporated daily checklists, EHR prompts, and peer audits to sustain momentum. These issues were addressed by flexible training options in person and virtual. Staff were also compensated for participation, recognition programs to encourage engagement, And we use current tools to keep costs low, as mentioned previously, as well as daily checklists and leadership reminders for accountability. The initiative was truly a team effort. We involved nurses, respiratory therapists, educators, and leadership to ensure the training was relevant and feasible. And a dedicated project coordinator helped oversee communication and logistics. And most importantly, our patients, young individual dependent on ventilators, benefit from improved safety and consistent care. And we created a timeline for the span of 11 weeks of what we can accomplish and how we could develop a educational program that's sufficient for the dependent ventilator individuals. The literature reinforces the urgency of our project. Studies confirm that VAP is preventable, yet staff compliance is often poor due to training gaps or resistance. And the evidence shows that a multidisciplinary approach, ongoing education, and leadership support lead to better outcomes. Sustained interactive training rather than one time sessions is critical for lasting impact as well. For project results before the training, we conducted a pre-survey during a staff huddle with participation from 31 staff members across respiratory therapy, RNs, LVNs, CNAs, and the overall response was 60%. The results revealed key knowledge gaps, particularly in suctioning techniques and understanding why proper head of bed elevation is necessary for preventing VAP. And during the educational session, discipline leads from nursing, respiratory therapy, and quality led brief focused presentations on VAP prevention and compliance risks. These were supported by live demonstrations and short engaging video, followed by a mandatory 5-question quiz that staff had to pass with 100%. And the post survey was administered during a leader huddle and showed a significant improvement, which participation jumped across all disciplines and average scores rose to 85%, which demonstrated enhanced understanding. We also used feedback forms, which confirmed the staff felt more confident in applying VAP prevention strategies. Additionally, observational audits showed measurable movement in documentation of oral care and consistent use of appropriate head of the bed elevation. And overall, these results directly addressed the original problem of inconsistent staff knowledge and compliance by closing these knowledge gaps and improving confidence. The initiative helped foster safer, more consistent VAP prevention strategies across the facility. To evaluate the impact of this initiative, we use both quantitative and qualitative methods. Quantitatively, pre and post surveys were critical in measuring change in baseline knowledge and engagement, and the quiz helped ensure full comprehension and the increase in post survey scores, along with improved response rates, which confirmed the success of the training in boosting VAP related knowledge across disciplines. On the qualitative side, post survey feedback and staff confidence ratings helped us understand how comfortable team members felt in applying that what they had learned. This was further supported by real-time observational audits, which showed staff were following protocols more consistently, particularly in areas like oral care and maintaining head to bed elevation. Together, this data provided strong support for proposed initiative. The clear improvements in knowledge, confidence, and observable behavior indicated that a structured, multidisciplinary educational approach is both effective and sustained for enhancing VAP prevention in pediatric subacute care settings. In conclusion, the project clearly showed that targeted hands-on education made a meaningful impact on staff knowledge and confidence, and the improvement in quiz scores and observed behaviors confirms that structured interactive training can help close long-standing gaps in VAP prevention practices. In relation to the literature and the theoretical framework, my findings echo what previous studies have shown. When education is practical, consistent, and supported by leadership, staff are more likely to comply with infection protocols. And the use of a multidisciplinary team also supports the scope and theory behind collaborative care as a key driver for quality improvement. However, the project had limitations. We did not collect data on patient outcomes, so we can't directly measure how these education affected VAP incidences. Additionally, time constraints and varying levels of baseline knowledge may have limited the depth of engagement during the intervention. For future recommendations include VAP education part of onboarding and annual competencies, and using quality dashboards to confirm practice trends, and adding patient outcome tracking in the future iterations to better assess long-term impact, and encouraging a culture of ongoing education and accountability will definitely be vital to sustain these improvements and driving continued advancements in respiratory care. Thank you so much for listening to my presentation.